You're listening to Medscape's In Discussion series on lung cancer, a podcast where thought leaders and clinical experts share their diverse insights and practical ideas for optimizing patient care. This series is hosted by Dr. Jacob Sands, instructor of medicine at Harvard Medical School and physician at the Thoracic Oncology Program at the Dana-Farber Cancer Institute in Boston, Massachusetts. Relevant disclosures can be found with the episode show notes on medscape.com. The topics and discussions are planned, produced, and reviewed independently of advertisers. This podcast is intended only for U.S. healthcare professionals.
Hello, I'm Dr. Jacob Sands, thoracic medical oncologist at Dana-Farber Cancer Institute. Welcome to Medscape's In Discussion series on lung cancer. Today we'll be discussing biomarkers and targeted therapies for lung cancer. First, let me introduce my guest, Dr. Pasi, Director of the Lowe Center for Thoracic Oncology at the Dana-Farber Cancer Institute and Professor of Medicine at Harvard Medical School. Welcome to In Discussion.
Thank you. Pleasure to be here, Jacob.
Now, before we get started, question about your journey, just how you ended up focusing on lung cancer and your path to your current position.
I trained at the Dana-Farber as well as a medical oncology fellow. And during that first year of training where you rotate through all of the sort of specific diseases and disease centers, I really got interested in studying lung cancer. I thought it was a disease that was interesting both from a medical standpoint because it was a very multidisciplinary disease, but also it was a disease which unfortunately still continues to be the number one cause of cancer death for both men and women in the United States and was back then as well. And unfortunately, it was one where therapies have not advanced as much as they had, for example, in hematologic malignancy. So I thought that there would be potentially an opportunity to do something in this disease. And then was another reason I ended up deciding to pursue a path in lung cancer. And then finally, I would say, I found a mentor, Bruce Johnson, who still continues to be my mentor to date. And that was another big deciding factor into deciding to pursue a career in thoracic malignancies.
That's actually a great starting point to highlight the fact that lung cancer has been so deadly, because we're going to talk about what incredible advances have happened over the last 10 years. And of course, you've had a huge impact on both the biomarker testing as well as targeted therapies. And if we go back to IPASS, which is now about 11 years ago, has that been as surprising to you as well to now reflect back and over the last 10 years to see so many different targets that have been identified with FDA-approved treatments for each of these? Or is this what you kind of envisioned at the time of that early EGFR work?
I don't think we envisioned that we'd find so many other targetable subsets of lung cancer. It's, of course, wonderful to see that we as a group have found that. And, of course, the impact that's having for patients with lung cancer. A lot of the sort of principles of targeted therapy, we still kind of revert back to EGFR mutant lung cancer because it was the first one around and it's been studied probably the longest. And we've learned a lot from it that has helped, I think, the development of some of these other subsets of lung cancer with targeted therapies.
Now, before we get into the testing and the treatment, let's just start with kind of the basics. What is it that makes a genomic alteration potentially targetable? Even before drugs are developed, what's the kind of alteration that would make that something that would even be worthy of looking for or developing drugs to target? What makes it targetable?
Well, I think in the case of all of the sort of subsets that we have in non-small cell lung cancer and other cancers, these are genetic alterations that turn on proteins in a constitutive fashion. So, for example, EGFR mutations force EGFR to be continuously on. And it's that continuous on process that converts a normal cell into a cancer cell. And normally, this is a very tightly regulated process of on and off, but these mutations force it into going on all the time, and it leads to cell growth because of that, and again, converting a normal cell into a tumor cell. And so because it's so critical in that process, it's really the engine essentially. And so it's so because it's so critical, it makes it also a good potential therapeutic target if you can develop a therapy against that.
Great. And then we're going to jump into now the various testing options. There are different technologies for testing. I know there's been increasing discussion about NGS and a push for NGS, and we can get to that. But before we do, What are the different ways of testing, just from PCR and NGS, I suppose, being the most common?
So at the moment, when somebody is diagnosed with non-small cell lung cancer, we'd like to test them for all the possibilities of targeted therapies. And there are 7 or so approved different agents for specific targetable alterations at the moment. And so you can test them individually. You can test an EGFR mutation, and if you don't find that, then you can test for a KRAS mutation or an ALK rearrangement, et cetera. So you can do sort of sequential testing, which I think still happens in some places and used to be more popular, but takes time and often depletes the very valuable tissue resources for that. Or you can do a more comprehensive single test, which is what next generation sequencing is, or NGS tests comprehensively at the same time for all of these particular alterations. And we typically do it from an actual tumor biopsy, but of course there's technology to do it from circulating tumor DNA as well. And these two are often used in a complementary fashion. For me, I think the standard of care is broad-based testing to look for one of the potential targetable alterations, because we know from the clinical studies that if you find a targetable alteration, getting a targeted therapy as your treatment is the right choice.
Yeah, and I do still see centers, I'm sure you do too, particularly referred in, where they've had kind of a handful of tests done, and those are often PCR-based tests, which is one-off, as you mentioned. These tend to have historically really been done in part due to lower cost, quicker turnaround on the results. But as you point out, the NGS testing, the more broad-based testing, really allows for, one, you can use less tissue to get all of it. But two, one aspect that actually I haven't heard discussed as much is when there is something that we don't yet know to test, but down the line becomes actually something that's actionable. So I have a patient who had a RET fusion that was seen on initial NGS testing. This was prior to actually having any RET inhibitors available. And she'd been through a handful of lines of therapy and was really at the point where we didn't have much more to offer her. And I actually had a discussion with her about hospice. And a week later, I found out that we were opening the phase 1 of LOXO 292, which ended up being selpercatinib. And so I actually called her and said, hey, we actually do have a trial that's opening and you qualify. And the only reason I even had that was due to the NGS testing that had been previously done back when we didn't know to test for RET because it wasn't yet something. And of course, that she was one of the first people on the trial and really did very well on it. And that is now an FDA approved treatment. And so it's more a statement to the listeners that even though we have a list of specific alterations, and sometimes I hear people say, well, they want to just limit the testing to what has approvals, but actually having more broad testing can lead to future options as well.
No, absolutely, and can direct individuals to new and novel clinical trials, not just the RET example that you mentioned, but there are others as well. And I do think that there's value in that comprehensive testing. And similarly, I think we will learn, even though we find an actionable genetic alteration, let's say an EGFR mutation, we will also continue to learn what do the other genetic alterations mean in that NGS report, meaning that are there going to be instances whereby the other alterations somehow dictate how long someone will benefit from an EGFR inhibitor, or will they dictate whether somebody needs an upfront combination strategy versus a single agent? So I think there will continue to be value in doing the comprehensive testing for not only identifying new potential therapeutic options, but even how the genetic alterations may modulate existing therapeutic options.
Well, that's a perfect transition, actually, to now discussing the treatment. And there are multiple alterations to discuss. Let's start with the first one being EGFR mutations, and that's kind of understood to be sensitizing mutations. But of course, there are some differences. And so maybe you can just highlight when we speak of EGFR mutations and we're talking about targeted therapy for EGFR, and then going into the sensitizing mutations and the multiple drugs that have been developed to this point.
Sure. One way to think about EGFR mutations is that there basically are 3 categories of EGFR mutations. There's the most common ones, which are the exon 19 deletion and the L858R mutation, which account for about 85% of EGFR mutations. And this is where we have all the vast majority of drugs approved including osimertinib, which is the sort of the standard of care in this situation. Then we have what are called, sometimes referred to as atypical EGFR mutations. So these are mutations in the exon 18, like G719 or L861Q, and this is where afatinib has specific regulatory approval. And then there are the exon 20 insertions, which have been, to date, the most difficult ones to treat and account for about 5 to 10% of EGFR mutations. There are two drugs that are specifically approved, amivantamab and mobocertinib for the exon 20 insertions, and many others in clinical development. But it's been a tougher subset to treat compared to the more common ones.
You've, of course, been involved in the development of osimertinib and have spoken at ASCO and led some of those publications. I know that's what most in the US, I think, tend to use, but there are an array of different options. Can you just go through those?
Sure. So there's osimertinib, there's afatinib, dacomitinib, gefitinib, erlotinib, ramucirumab combination. So osimertinib, as I mentioned, is the standard of care out of all of those for a couple of reasons. One is that in the FLORA trial, osimertinib was compared to standard of care EGFR TKIs, which were really gefitinib and erlotinib, depending a little bit on which part of the world the trial was being conducted in, and showed an improvement in not only progression-free survival, but overall survival in that situation. Second, many of our patients, unfortunately, suffer from brain metastases, and osimertinib is a drug that can effectively cross the blood-brain barrier and treat pharmacologically brain metastases. And if you look at in the FLORA trial, where it was compared to the standard of care EGFR TKIs, there was a lower incidence of developing brain metastases in patients who started on osimertinib compared to standard of care EGFR TKIs as well. And I will say it's also now approved in the adjuvant setting once you've had effective surgery and or standard of care afterwards, which is chemotherapy for patients who have EGFR mutant non-small cell lung cancer. Osimertinib had shown an improvement in disease-free survival compared to placebo in the adjuvant setting. And so it's got a couple of different approvals. And as you mentioned, in the US, most patients with the common EGFR mutations today start with osimertinib. Now, having said that, unfortunately, people with advanced EGFR mutant non-small cell lung cancer are not being cured with osimertinib. And so there is an opportunity to build on that success. And there are many clinical trials trying to add a second agent or add chemotherapy to osimertinib. And many of those trials are being conducted at the time or have completed enrollment. But so far, very limited data exists on anything in terms of efficacy. And for the moment, single agent osimertinib remains standard of care.
And at the time of progression, of course, we end up doing genomic testing at that point. Can you go into, one, the reason for that genomic testing, and two, some of your experiences around how that's impacted treatment?
Sure. Well, the reason to do genomic testing at the time of progression on osimertinib is that many of the mechanisms of resistance to osimertinib are also genomic, meaning that there could be a second alteration that could also be targeted. So, for example, a common one is something called MET amplification, where there's more copies of the normal MET gene, and it can sort of circumvent the need for EGFR inhibition. And if we find that at the time of progression to osimertinib, there are clinical studies showing that adding a MET inhibitor to osimertinib can resensitize that person's cancer to that combination. And so it's finding things that you can target at the time of osimertinib resistance. I think the bigger challenge remains, what do you do if you do all that testing, you don't find anything that you can target, and what's the right thing to do at that point? Oftentimes we revert to chemotherapy at that point, but I think we're looking for the optimal therapeutic approach in that situation. But the real reason to do the testing is to find things that you can target, and you can do the testing from a repeat tumor biopsy or blood testing. Repeat tumor biopsy is also useful because sometimes these cancers, which are always start out as adenocarcinomas, can transform into other subtypes of lung cancer, like small cell lung cancer or squamous cell lung cancer. And there, that dictates specific chemotherapeutic treatments if you find that in the tumor biopsy.
And often the discussion I have with patients is to phrase it, as long as they're not having a lot of symptoms and whatnot, and there's not a rush, to help allay some of the anxiety around wanting to get started immediately. I'll describe that we really want to get them on the best therapy, not the first therapy. But if their symptoms start getting worse, or if there's some reason we need to get going, we can get them on the first therapy being chemotherapy. And so the point I often make is that if we don't have genomic testing back, then doing just the chemotherapy and holding off on immunotherapy until we have full genomic testing and no targeted therapy options. Is that your practice? And do you have reservations about putting people on immunotherapy without yet having the genomics back? What is your thought process around that?
Yeah, I mean, I think many times there is time to wait to get the genomic testing back for the reasons you mentioned, to find the best therapy for that individual, not the first therapy. Obviously, there is sometimes need to begin treatment sooner than sequencing is back, which can take a few weeks, and sometimes that time is too long. In terms of the question of immunotherapy, right? So one of the challenges is that the half-life of many of our immunotherapeutic agents is quite long. And meaning that even when you're ready for the next treatment, if you measured them in the blood, you would potentially still find the anti-PD or PD-L1 antibodies there, or the drugs there. And what we know from the targeted therapy field is that combining targeted therapies, for example, EGFR inhibitors or ALK inhibitors with immunotherapy, has led to a lot of toxicity without a lot of potential benefit. And so I worry a little bit about starting somebody on chemotherapy and immunotherapy, and then by the time they're ready for their next treatment, you, for example, happen to find that they have an EGFR mutation, you want to put them on osimertinib. I worry about that potential interaction with the immunotherapy from the prior treatment. So I often start them on chemotherapy like you do. And then you can always add the immunotherapy later if you don't have a targetable alteration. But I tend not to start with that, especially someone who I suspect may have a targetable alteration. For example, someone who does not have a background of cigarette smoking or very limited smoking, where there's a greater than average likelihood of finding a targetable alteration.
Yeah, if there's maybe a handful of things to take away from this is in there to not start immunotherapy until you have back the genomic testing due to the risk of pneumonitis, especially as you've described. So to that point then, at the time of progression on osimertinib, if there's not an actionable alteration and you're now going to chemotherapy, what are your thoughts around immunotherapy at that time? And there's different data on this. I don't think there's tons of data in this setting. Some trials have involved EGFR, although I haven't seen the degree to which that's actually sensitizing for mutations versus others. But what are your thoughts in that setting? That seems like the setting of a lot less data to really go on.
Yeah, I would say the data is pretty clear that our current immune checkpoint inhibitors do not work very well in EGFR mutant cancers. Even if they have a high level of PD-L1 expression, the efficacy tends to be shorter and much more short-lived. I think if someone progresses on osimertinib and you're deciding with chemotherapy, I think one decision point, which is often a discussion with the patient, is do you continue the osimertinib with the chemotherapy, or do you stop the osimertinib with the chemotherapy? Now, there isn't a right or wrong answer here. There is an ongoing trial that's trying to evaluate that approach. If someone has had prior CNS disease and has responded to osimertinib, I think most of us have the tendency to want to continue osimertinib with chemotherapy, because we know that chemotherapy doesn't necessarily cross the blood-brain barrier as well as osimertinib does. And also, resistance isn't completely black and white. It's not that everything becomes resistant simultaneously. There may be part of the cancer that's still being kept under control with osimertinib, and taking that off could lead to a kind of a flare reaction where there could be more a growth of that disease. But it's a little bit of a data-free zone, but certainly a discussion with the patient as to what to do at that time. And if you continue osimertinib, then absolutely no immunotherapy because of the potential interaction, as you mentioned. Really, mostly pneumonitis is the main concern there with osimertinib. And with other inhibitors, it's liver toxicity, et cetera. So, but there is definitely more toxicity if you use a TKI and immunotherapy together.
EGFR exon 20 insertions has been a real challenge. And recently there's been quite a bit of progress in this. So as you mentioned earlier, we have 2 FDA-approved drugs in this setting. There was some data presented at ASCO about another regimen. What is your current practice for EGFR exon 20? What are your thoughts between the 2 FDA-approved regimens and then as a follow-up, the recent reported data?
Sure. So the currently approved agents, amivantamab and mobocertinib, are really second-line agents at this point. They don't have quite the degree of efficacy as osimertinib does, for example, in the common EGFR mutations, and really should be used as second-line agents after first-line chemotherapy. I don't think there's a right or wrong answer as to which agent do you start with first. Do you start with amivantamab and then mobocertinib, or vice versa? One's an antibody, one's a small molecule inhibitor. They work by completely different mechanisms. We know very little about if you become resistant to one, can you still respond to the other? And we also know very little about the mechanisms of resistance to these two different agents, something that we'll hopefully learn about over the next several months to years, and how to best sequence these if they're both being used in the second-line setting. There have been a number of agents that have continued to be studied in this space, and there was some data on a few of these at ASCO, and continue to look promising. One of the challenges with the exon 20 insertion agents typically is toxicity, and they typically have sort of wild-type EGFR toxicity, rash or GI toxicity. And so trying to find the osimertinib equivalent for exon 20 insertion, I think, remains the holy grail. To find something that has a response rate of 60 or 70% with minimal toxicity would be fantastic. I'm not sure that we're there yet, but there's a lot of ongoing efforts in that space.
Well, we've covered a lot today around testing and then specifically around EGFR treatment options. And so just to quickly go through that as a summary, different ways of doing genomic testing for actionable alterations, which you defined as essentially the alterations that end up being oncogenic drivers, and therefore shutting them off can then have impacts in the treatment. We discussed PCR testing as a quick and less expensive way of doing testing versus NGS, which is a more broad-based testing, and really highlighted the value of having that broad list of genomic alterations that can guide treatment across all of them, as well as ones that lead to clinical trial enrollment, or ones that later on become relevant within trials and aren't even necessarily known at that time. We also discussed the importance of getting back the genomic testing results before starting any immunotherapy, generally before starting treatment, I'd say. But if you really need to start with treatment immediately, then giving just the chemotherapy to really reduce the possibility of risks from initiating targeted therapy, namely osimertinib and checkpoint inhibitors was the specific combination we discussed that can cause pneumonitis. We also discussed that at progression, it's important to, again, do genomic testing, because this is how we find other actionable alterations that can sometimes be next line options. But if there aren't any, chemotherapy without immunotherapy, or chemotherapy even with osimertinib, although Dr. Jänne, you highlighted the fact that there's not a ton of data in this, and some various ways of thinking about that next line treatment. We also discussed exon 20, which has been a real challenge, although recently now has some FDA-approved therapies, and there are 2 FDA-approved therapies, both of which are certainly usable and certainly more research to do. And we didn't go into all of the other actionable alterations, but there are a lot. And this is just essentially one aspect of a much bigger topic. And this has really been an exciting decade within oncology, and just tremendous progress within treating lung cancer. And with that, I would like to thank our listeners for joining us. This is Dr. Jacob Sands for In Discussion.
Thanks for listening to Medscape's In Discussion Lung Cancer podcast series with our host, Dr. Jacob Sands. Be sure to look for more In Discussion episodes wherever you get your podcasts. Check out medscape.com for show notes, links, and more information on lung cancer.